What's up, everyone? Welcome back to the Daily Sean. For those of you who haven't been here before, my name is Sean. I do a daily video on something related to nursing. No rhyme or reason. Probably not going to change. I think I've figured out nursing. I don't know why it's taken me so long. Maybe I'm a slow learner. But nurses have to master living in the middle. Gee, Sean, what do you mean by that?
Let me explain.
We have to master living in the middle because we don't do well in the extremes. And what I mean by that is our patients, the people we care for, or the peripheral responsibilities of assisting the patient's family, friends, or visitors. We have to live in the middle. We have to master the middle. Can't live in the extremes. Here's some examples. Bowel movements. We sure don't want them not going at all because constipation is a very bad thing. It causes all kinds of badness, and I don't really think I need to explain the badness. Constipation's bad. It can lead to, in worst case scenarios, surgery. Because if you perf your bowel, yeah, that's a bad thing. The very least of which is that it causes a significant amount of pain. So, we don't want our patients not going at all. But we don't want our patients going non-stop. We want the river to slow down at some point. Because then if the river's still going and there's no end in sight, then we're worried about other extremes. Do they have an infection? Do they have C. diff? Is there something else going on? An obstruction? Do they have something wrong with their bowels? Are we giving them medications? The list goes on. Going too often is also a bad thing. You want to live in the middle. Emptying your bladder. Another completely obvious middle. You don't want them going at all, not at all. Hello. Kind of want your kidneys to work. Not going is a sign of something else going on there. Now, we're not talking about like dialysis patients. That's just unique because some dialysis patients still actually make urine. Let's not blanket that one. You have to at least produce some urine. Unless it's your norm. Which is not usually the norm of patient. The norm of the norm. Is that even a word? Is that even a concept? Anyway, you know what I mean. You gotta go. You can't just not go. There's something going on. Maybe there's an obstruction. Maybe you're dehydrated. Maybe there's something wrong with your kidney itself. I don't know. Flip side, we don't want you going non-stop, okay? Because that causes all kinds of badness in that respect as well. I mean, you got a kidney problem going on, you have SIADH going on, is it a DI problem, salt wasting, is there something going on with your brain, or is there something going on with your adrenal glands, or any number of neuroendocrine problems. We don't want you going non-stop either. Case in point, we also want you to be able to have control over both of those bodily functions. Living in the middle. Get my point? Not yet? Let's keep going. How about neurological assessment? And this can include someone who's intubated or not intubated. On a BiPAP mask, on a nasal cannula, or just good old-fashioned room air. You don't want to live in the extremes. You don't want them completely somnolent, sedated, and obtunded because there's something wrong there. Gee, are they hypercarbic? Are they retaining CO2? Is there something going on with their liver? Is their ammonia level through the roof? Have they had a brain aneurysm, a stroke? Is it something that has to do with their heart? Is their heart even beating? So the list goes on. Case in point, you don't want to be completely out of it. I want you to be able to respond to me. Okay? Completely opposite end of the pole. I do not want you scraping at the walls, having to pull your shit off the ceiling, okay? No, I don't want that either. I don't want to have to chemically or physically restrain you. 4-point leather restraints are not fun at all. Especially if you don't have control of the first two things that we talked about. 4-point leather restraints, uncontrolled bowel and bladder. I mean, really? Do I even need to explain how bad that is? Yet, and this is a big one, I'm pretty sure all of us have had to deal with that in some way, shape, or form. So, hyperactive, crazed out of your mind, cuckoo for Cocoa Puffs is also not a good thing. Living in the middle. Alert and oriented to some degree. Responding in some way. The list goes on. Shall we even talk about your vital signs? We don't want your heart rate in the toilet, so I would really appreciate it if your heart beat more than 20 beats a minute. And I would really appreciate it if it wasn't beating 200 beats a minute. Okay? You get the point. Blood pressure, pulse ox, pain scale. The list is absolutely unlimited. Yeah. We nurses have to find a way of mastering the middle. It is your job, along with help from your team of other professionals in the multidisciplinary team, to try and find the happy place, to find the happy middle. You have to become a master of the middle. You have to be a middle grounder. Is that even a term? Anyway, you get my point. You gotta live in the middle. It is a seesaw battle every day of figuring out how to get your patient as a whole into the middle. This has been a public service announcement to all of my nurses out there. I have solved our problem. Our job has been whittled down to becoming middle masters. You're welcome. What do you think? Want to hear from you. Have you mastered the middle yet? Leave your comment down below. Your comments are McAfee. Share this with somebody. And as always, check your own pulse first.